We're practicing headache at a very exciting time. So finally, we have drug specifics for patients with migraines. And along the lines with what we heard already about the recent advancement in the field of migraines, give me the great pleasure to introduce our first speaker for this symposium, Dr. Jacques Shim. He's a practicing neurologist coming from the University of San Diego, where he's trained in headache as well as in neurology. He's board certified in neurology as well as he's board certified in headaches. He's been practicing in the United States in San Diego for several years, and he has published extensively in the field of headaches. Dr. Jacques will be speaking to us and updating us about the recent management of headaches from acute to preventive treatment. But before we do that, I think we have a poll, if I'm not mistaken, that we can share with you before we get started. This is my disclosure. It has nothing to do with the presentation. This is the poll. I don't know if you can do it online, but you can also do it from here. And the question is, anti-CGRP class is an effective class with a confirmed mechanism of action. It's used for how to treat patients that had unsuccessful experience with one or two oral preventive treatment. So that's one option. The second option, that you would consider anti-CGRP as a class for specific patients who has, keeping in mind a good balance of efficacy, safety, which why I prefer to use it in my treatment approach for patients who had more than 4 migraine headache days that need to be initiated on preventive therapy. So when would you consider starting anti-CGRP? For patients who are hard to treat, or for, let's say, newly diagnosed migraine patients, and you want to hit early on with the right treatment for these patients? So you have 50-50 chance to pick one of these choices. Hard to treat, or basically naive patients with migraines, any patient with migraine that you believe anti-CGRP should be considered for. I see it's quite split, actually, 50-50 pretty much. We'll see if this will change at the end of the talk. So I think now we can get started with the first speaker. We're going to have this recorded, but at the end of the session, unfortunately, Dr. Jacques will not be available to answer questions, but we do our very best, if you have any questions, to answer them after the second speaker. Thank you very much.
Hello, and welcome to a presentation on Egality and Rayvow, Real World Experience 2022. My name is Dr. Jacques Shim. I'm a headache neurologist in San Diego, California. My disclosures are listed here. You can see I've been a consultant for a number of companies. I've done clinical research for a variety of companies in the headache world. And I've been a promotional speaker for a number of companies as listed. First, I'd like to give a little thought to prevention guidelines from the American Headache Society statement on integrating new migraine treatments into our therapies. To start with, we consider preventives based on headache frequency, migraine frequency. So if someone has frequent attacks, say 3 or 4 migraine days a month, that should be sufficient. If the attacks interfere with someone's function, they should be offered preventives. If they have issues with acute medicines, contraindicated, failure of those medicines or overuse, or for that matter, side effects. And then patient preference, of course, is another good reason to offer someone something. You know, what we say is the best migraine is the one that we can avoid. The existing preventives, meaning prior to the CGRP therapeutics, have lots of challenges. We talk about these now as the legacy preventives. So to start with, based on headache frequency and these other considerations I just mentioned, about 40% of people with migraine could benefit from preventives, but only about 15% of people with migraine that could benefit actually are on them. About 80% of people who are put on a preventive, any of the standard we'll call them legacy preventives, things like beta blockers, topiramate, and so forth. 80% have quit them within a year. And the two big reasons, of course, are simply didn't work well enough or side effects. The legacy preventives, we really struggle to get people even a 50% improvement for half of people. So let's look at an individual patient. This lady is 34 and has a busy life. She's a teacher, she has 2 children. She's had a history of sinus headaches. And I think most of us recognize that that's often a misnomer for migraine with autonomic features. They date back to her mid-teens. She's had some rather typical triggers, menses, weather changes, and she experiences frontal pressure, stomach upset, and finds it difficult to function. I think those are leading us towards a diagnosis probably of migraine. She's previously treated with naproxen. She has a couple of other issues, not so rare, a mood disorder and asthma. After childbirth, her headaches got worse. Well, we know that migraine headaches are often hormonally linked, and she's now estimating 3 or 4 attacks a month, and they can last up to 2 days. So if you think about that, she's having anywhere from maybe 3 to 8 bad days of dysfunction due to her headaches. She's been treated for depression with duloxetine, and it helped her mood. The primary care doctor interviewed her and diagnosed migraine. She kept a diary, and I think if we look at this in a rather broad sense, I would say she, first of all, has a lot of headache days. She doesn't quite fit chronic migraine, but if I count it up, she has about 16 days of no headache. She has, about a half dozen to 7 days of migraine level headache, and she's taking migraine type meds on several days. She fits the diagnosis of high frequency episodic migraine. Propranolol was added, standard treatment, titrated to 40 milligrams twice a day, and she was given sumatriptan 50 milligrams as needed. That helped her headache some. She still has about 6 migraine days per month, and again, worse around her menses. Galcanezumab was added. She was given a loading dose, which is standard. So that's 240 milligrams first month, 120 milligrams each month thereafter. 2 months later, she was seen in follow-up, and she noted that her headache frequency had dropped. She noticed improvement, actually, even in the first month, and now she's down to about 3 or 4 days per month of impairment. She stopped sumatriptan because she found that rizatriptan was a better choice. A little bit further follow-up now at 3 months. At 12 weeks, she's now down to 2 attacks a month, controlled in a day. So she's gone from, what did we come up with? Maybe 15 days, 14 days of headache and there for high frequency episodic now to 2 days, and her crystal clear days are improved substantially. She also noted that her mood has gotten better, not because the duloxetine alone, but because she has better control of the headaches. A lot of people with migraine have anticipatory anxiety. People know that, of course, they can't predict when they're going to get a headache, and that makes things very frustrating. It's very difficult to plan their life. Well, so what's some of the data about galcanezumab? This is a little bit of a summary from the double-blind phase of both EVOLVE-1 and EVOLVE-2. These were the pivotal trials that investigated galcanezumab. This is looking at the 120 milligram monthly dosing. In the trials, there was also a group of people that were treated with 240 milligrams monthly. As it turned out, that didn't really show any distinction over time compared to 120 milligrams. So the approved dose is, after a loading dose of 240, 120 milligrams per month. So a couple of takeaways here. First of all, improvement in the very first month. In fact, statistically significant at the first week and every week thereafter through weeks 2 and 4. You can see the improvement. This is the gain over time. This is an episodic migraine population. So this is a 6-month study. The 2 trials basically show similar results. Of course, there's always response and placebo, but the response with galcanezumab was substantially better at all time points. This is looking at the information that I think is really exciting to me, looking at the results in the very first week. So in the very first week, significant improvement, in fact, from day 1 in both the episodic and chronic migraine trials. So EVOLVE-1 and 2 were episodic migraine trials. REGAIN was a chronic migraine trial, and you can see progressive improvement in the first week, both with episodic and with chronic migraine. Something that is, I think, very important to recognize is that our patients don't really resonate with the idea of 6 days, 7 days, 8 days, 4 days fewer of migraine. In other words, depending on their headache frequency, they'd much rather understand, what's their likelihood of success? And that's better conveyed by response rates. So what I've highlighted is the at least 75% response rate. We tend to look at 50% response, and that's good, but we're looking for great, right? So if someone starts off with 7 or 8 days of migraine, which was rather standard in the Evolve-1 and Evolve-2 trials, if they get better by half, gets them down to 4. If they get better by 3/4, they're down to 2 days a month. That's much more manageable, and quality of life is much, much better at that point. You can also note that there's a substantial fraction of people that were 100% better for at least 1 month over 1 through 6 months. And while that may not look that impressive, 12, 16%, note that that's more than twice the incidence of that degree of improvement in placebo. So this is not only statistically significant, but clinically significant. This is looking at the 75% response at month by month. And I think this really makes very good sense to me. If a medicine is likely to work, it's likely to get better over time, right? We've seen that with all of our oral preventatives, but with the oral preventatives, we know that an awful lot of people have to stop them because of side effects. With galcanezumab, there was a very small fraction of people stopping due to side effects, adverse events. So month 1, 26% of people at least 3/4 better. By month 6, 44% of those receiving actual drug compared to 25% of placebo-treated people. Well, something that, I think patients have asked me, how can a medicine that's dosed once a month, has a 27, 28-day half-life, a Tmax of about 6 days, how can that really work time after time and month after month? And what we're seeing here is that there's really no drop-off of benefit over the treatment period over 6 months, consistent improvement over the baseline, consistent reduction of headaches at all weeks of every month throughout the study period compared to placebo. This is another way of looking at this. This was of individual patients with high-frequency episodic, looking at how many of them, if any, had wearing off at 2 months and at 3 months. And the answer is, it really does not seem to be problematic. So this was defined as an increase of at least 2 migraine days in the last week of a treatment compared to the second week for at least 2 months. So very few people are experiencing a wear down. Tolerability, of course, is important to be aware of. The most common of adverse events in galcanezumab trials was local site reactions. So that would include things like redness, soreness, or pain. This is not an allergy. This is just local irritation from a shot. Typically that occurred on the day of injection and typically goes away within a couple of days. I've definitely had patients who said to me, I get this red spot. Is it okay for me to keep treating? And the answer is, because it's not a systemic reaction, it's absolutely okay. People may have it one treatment, not another. They may not experience it at all. So in general, these were mild to moderate. There were no serious, severe reactions of this sort. And then on the right side, you can see the breakdown of what are the terms that led into this overall injection site reaction terms. So pain, redness, swelling, itching, and so forth. You can see some of the other adverse events that showed up in the trials that were low incidence, specifically noting hypertension was not problematic, constipation was not problematic. So things that we would know our patients don't really want to experience, systemic issues, did not really turn out to be problematic with galcanezumab. Local irritation has been seen with all of the medications in this category as their most common of adverse events. So let's just pivot for a moment. We've been talking about preventive care with Emgality. Let's talk about what do we do for acute treatment. First of all, anyone who has migraine should have an acute treatment that's effective and hopefully migraine specific and well tolerated. And this shows what are guidelines across regulatory bodies and the Headache Association. So first of all, the European Medicines Association recommended that the primary endpoint would be pain freedom, 2 hours post-dose. The FDA likewise has recommended pain freedom, and in the newest of studies, simultaneously meaning pain freedom and relief of most bothersome symptom. The International Headache Society recommends looking at the percentage of people that become pain-free after 2 hours. So focus on fast results, and this is looking at one and done, in other words, without use of a rescue medication. And the American Headache Society likewise endorses rapid, consistent freedom from pain and the associated symptoms without recurrence. By the way, the most common of associated symptoms, most bothersome migraine-associated symptoms across trials has been light sensitivity. Problem is, of course, that our usual meds don't always meet people's needs. So this is looking at people from a large trial in Cameo with over 11,000, almost 12,000 respondents. And nearly 60% of these individuals had at least one unmet acute treatment need. They still had disability from their headache despite taking an acute medicine. Many of them, more than half, were dissatisfied with their treatment. Unfortunately, about 10% were using opiates or barbiturates. And we know that those medications can lead to medication overuse headache. They can induce sensitization, which of course is the opposite of what we're looking for with migraine. And if people don't have good care, they can end up in an emergency department. There they tend to get opiates, barbiturates. They often are diagnosed correctly. They're sent out with a diagnosis of acute cephalgia, which basically means pain in the head. So what about another patient, another example here? Young man who's been having migraines since he was 8. He has a high-level job in investment banking. He's been treated with preventive, propranolol, still getting some attacks. He's been on 2 different triptans, didn't have ideal results. He's used non-steroidal medicines. And his migraines cause tiredness and fatigue, and he gets dizziness with his triptans. So he has to weigh the benefit or the possible downside of his medicines. He has to say, is this particular attack bad enough to take a acute medicine, a triptan, when I know that the medicine itself may make me feel worse before it makes me feel better? Rayvow is a ditan, lasmiditan, and it comes in doses of 50 or 100 milligrams. So he was trialed on 100 milligrams, and first response, I think this works. He noted improvement very quickly, 30 minutes the first time around, and he was pain-free at 2 hours. He noted improvement of nausea and light sensitivity, and he reported a little tiredness and lightheadedness for an hour or so. Sometimes it's hard to tell whether that's the migraine or the medication, but it is well within the profile of Rayvow. His second attack came on while he was at work. He felt relief in 30 minutes, but still had a mild headache for a few hours. This was mild enough that he was able to continue to work. So when we talk about acute treatment, our scale for measurement has typically, since the triptan's been 0 to 3. 0 is pain-free. 1 is mild pain, no impairment of activities. 2 is moderate pain, impaired but not completely disabled. And 3 is severe, disabled, can't function. In fact, the World Health Organization has rated a day of severe migraine in terms of impact as potentially as bad as being quadriplegic or acutely schizophrenic for the day. So we certainly wouldn't tell our patients clinically to wait until their attacks are bad. He knew that it was bad enough that he couldn't drive, and that was smart. This medication does have a caution. Patients should not drive or use heavy equipment for 8 hours after taking it. And he noted maybe this isn't the scenario that he'll use it again, meaning at work. So this is a medicine that might be used in some attacks or not others. And next time he'll use it in the evening. So this brings up a toolkit approach where patients can look at their choices of options, might be able to use a non-steroidal for a mild headache, perhaps use a triptan for a medium intensity headache and Rayvow for a more severe headache. In fact, many people with migraine know that during their attacks, they really shouldn't be driving just based on their migraine. Well, Rayvow, as I said, is a different category. It's a ditan. It's a 5-HT1F agent. There's evidence from animal studies that it can cross the blood-brain barrier. It is very lipophilic. That adds to the possibility of greater mechanisms of relief, not only purely peripheral, but also central relief. We think that it works by blocking peripheral nerve activity, inhibiting CGRP release. That certainly seems to be identifiable in animal studies, and in fact is part of the mechanism of triptans. Triptans are 1B and 1D agonists. This is a 1F agonist, so it has a different mechanism And most importantly, not only does it have a different mechanism, but it does not have vasoconstriction. So patients who have vascular risk factors still can be treated with this as an abortive. And in fact, in its trials, people with vascular risk factors were allowed into the trials. The key trials are listed here, Samurai and Spartan. Samurai was single attack, as was Spartan, and you can see they were run in different locations. Samurai was run in the United States only, Spartan was run in the United States, United Kingdom, and Germany. Spartan looked at 3 different doses, 50, 100, and 200 milligrams. Samurai, only 100 and 200 milligrams. There is no 200 milligram tablet, by the way. For patients that want to take 200 milligrams, they take 2 100 milligram tablets at the same time. And Gladiator was a long-term open label safety study, captured response rates and things like that, but mainly it was to look at the long-term effect and be certain that this had good safety. So what does the data look like? First of all, this shows fast relief. So you can see that the timeline here starts at 1/2 hour. There's improvement seen as quickly as a ½ hour. 1 hour, we've got substantial number of people with pain relief in the 40 to close to 50% range. By 2 hours, it's 60 to 65%. So remember, relief means that the patient went from moderate or severe pain where they don't function down to either mild pain where they can function normally, get back to their activities, or no pain. So this is essentially saying that this has got a high response in getting people from bad migraine to functioning again. You can see a substantial spread from placebo, and you can also see that there is a bit of a dose response curve, but in fact, both 100 and 200 milligrams have rather similar efficacy, 50 milligrams, just a bit less. There's further data. This is looking at people who did not have good response to triptans or who did. So on the left side of the graphic, you can see people who had not had good response to triptans, and looking at the various doses, at least double, if not more than double, the response to the placebo-treated people. And even in those who had good triptan response, because this has a different mechanism of action, at all doses studied, there was benefit, statistically significant, as you can see, asterisk, especially at the higher doses of 100 and 200 milligrams. I mentioned that if people can get down to mild pain or no pain, that they can function. So specifically looking at lack of functional impairment, this captures the fact that over multiple attacks, from attack 1 all the way through 20 attacks, people consistently were able to get relief. And in fact, their ability to get free from disability went up over time, from about 65% with their first attack to almost 86% at the second attack. And this is looking at a variety of time points, obviously. So not all of that gain was in the first 2 hours. What we're seeing is for 2 days after treatment, single dose, no rescue, patients were able to remain functioning. The side effect profile with this medication clearly indicates that it has CNS penetration, at least from my point of view. Dizziness, fatigue, and paresthesias, as well as sedation, were all of the most common of adverse events, as you can see. Nausea was low incidence, and I think probably not different from placebo, but adverse events are not tested for statistical significance. But because of the CNS side effects, we do need to educate our patients that they should not be operating heavy equipment with this medicine. That would include driving, of course. Fascinating to me is that in Gladiator, the incidence of adverse events went down over time. These are people who tolerated it. Now, this is an open label study. So of course, one little caution is people who were not feeling well probably didn't continue in the study, but nevertheless, people did see a gradual reduction in the likelihood of adverse events at both 100 and 200 milligrams from attack 1 all through attack 5. This is an interesting article. This was written by Dr. Tepper and Silverstein and published about 2 years ago now, talking not about lasmiditan, but about migraine. A lot of people with migraine recognize that their migraine itself impairs them. I've had people tell me, even if they don't have aura, they don't feel well, they feel dizzy, they're lightheaded. They typically, if they are driving, they would pull aside, turn the engine off, put the keys out of their way. Our preventives commonly have adverse events. I'm sure you can think of different medicines, different side effects. In fact, if I named a side effect, you could probably name the medicine. We know that the triptans can make people lightheaded, so not to say that we should ignore this, just the opposite. I routinely review adverse events with my patients and their prior experiences with meds as I educate them about new medicines. I explain the basis for the caution with Rayvow. And then, of course, as I said, maybe not every attack is a Rayvow attack. Maybe some of the patient's attacks are such that they should not be taking it because they would otherwise need to drive and they don't have a safe way of getting from their current location to where they need to be at that point. The adverse events for driving safety is now a requirement by the FDA. What they did with Rayvow is they took a group of healthy volunteers, tested them at baseline. They were able to successfully navigate a online type of driving simulator, and then they were dosed with Rayvow, and at 90 minutes, they were not safe. They crossed the line too much, basically. In a separate study, different individuals were tested likewise, baseline successful. 8 hours after taking Rayvow, they were able to safely drive. And so as a result, there's an 8-hour rule. Safety information for Emgality is listed here, and this is straight from the prescribing information. I think something we all need to review. Contraindicated in people who have hypersensitivity to the medicine. No drug-drug interactions with Emgality. There's really little to no data about pregnancy or breastfeeding, so I personally avoid my patients taking that by educating them and say, you know, this is not a medicine to be taking if you're planning on getting pregnant in the next 5 or 6 months, because it takes about that long to fully clear it from the system. Lasmiditan likewise has basically no information, data that is, regarding pregnancy or breastfeeding, so likewise it should be avoided. This potentially could have a serotonin syndrome type of side effect because it is a serotonergic drug. So educate the patients about symptoms of serotonin syndrome, lightheadedness, dizziness, fever, confusion. With that, I thank you for your attention and I hope you have a wonderful Congress. Thank you so much.
As I mentioned earlier, unfortunately, Dr. Jacques will not be available for us to answer your questions because of time difference. But if you have any questions, we'll try to address them at the end of the symposium. Before I can introduce the second speaker for this event, just want to check your responses to the first poll. Show of hands, how many of you would consider anti-CGRP only for hard to treat patients, meaning patients who had failed more than several preventive therapies? Just show of hands, how many only would consider CGRP for hard to treat migraine patients? Interesting. Yes, for very few. How many of you now would consider anti-CGRP for any migraine patients who had more than 4 migraine headache days per month? I see more. Interesting. Well, okay, you have 200. You have actually double voting. You're the president.